So today when we finish up kidneys, we're just going to go over glomerulonephritis, talking about the nephritic diseases versus the nephrotic diseases. Finish up with kidney stones, and then we'll be done with renal. Take a break, and we'll start neuro after that. So this is a really good summary slide to kind of put together the different types of glomerular diseases. On the left, we have our nephrotic syndromes. Okay, mechanism, injury to the podocytes is what causes this. Remember, those podocytes provide the gate. They're a sieve, and it'll let bigger molecules through. As you start destroying these podocytes, bigger molecules can get through, and protein is the biggest one that's going to go through, or the next one that's going to go through. What this is showing you is that as you go from the nephritic side of one spectrum, to nephrotic, to the other side, which is nephritic, which is all due to inflammation, one side is more protein, the other side is all blood. So if you look at the nephritic syndromes, anti-GBM, small vessel vasculitis, a lot of hematuria, a little bit of proteinuria. Now on the other end of the spectrum, minimal change disease, high protein, not very much blood. So the nephrotic syndromes, on urinalysis, you will see protein in the urine. On the more the nephritic side of things, you will see red blood cells in the urine because there's bleeding going on. And we'll go through some of these diseases as we go through this section. But again, just to show you that they're on two sides of the spectrum. There is some overlap in between. Obviously, here's our lupus, which is always weird in how it acts. But again, lupus can present as a nephrotic or a nephritic disease. So glomerulonephritis refers to just the nephritic diseases. And because it's nephritic, we know it's inflammatory, what causes the problem here. It's inflammation. Immune complex disease, infection, and often results in hematuria. So a lot of blood in the urine on these patients. Several disorders may be caused by diseases specific to the kidney or systemic diseases with the kidneys becoming involved with it later on. They're going to have some combination of hematuria. They may have proteinuria, may or may not. Again, look at this spectrum here. Some of them will have protein, some won't. Reduced GFR and hypertension. The categories for nephritic diseases is what we'll discuss: acute glomerulonephritis, rapidly progressive, and chronic are the three major ones that we'll talk about. So here's our little summary slide with regards to glomerulonephritis. Remember, it's inflammatory, usually some underlying infection, and we'll go through it. So main causes: infection, group A beta hemolytic strep. So if someone has that, and then a week later they come in with bleeding in the urine, they start noticing the urine being a little bit darker color, it might be due to the strep that they just had. Infective endocarditis, here's our pneumonia, and sepsis. So again, it's inflammatory. There has to be some sort of underlying condition going on previously. Ask your patient, were you sick recently? Yeah, I had a cold a week ago, and now I'm feeling better, but now I got this. Ask your patient certain questions, you'll find out more information. Abrupt onset, again, a week, 10 days after the infection, so they got sick, and then a week and a half, 2 weeks later, they come in and they have all these problems. So again, hematuria, proteinuria, decreased GFR, and renal water and sodium retention. This is the acute phase for acute glomerulonephritis. Again, underlying cause, they were sick recently. So etiology, pathophys for this acute glomerulonephritis. We get cross-reactivity between an antigen and the infecting organism. What this does, it activates our inflammatory cells. Once our inflammatory cells are around, they start infiltrating our glomerular walls, And this creates antibody-antigen complexes. The antigen, the foreign antigen, the antibody that our body is producing, they combine to make a complex. And this gets deposited in the wall, depending on what part of the wall. We'll go through that in a second. But now we have this inflammatory cytokines complement in the area that is all going to attract neutrophils and monocytes. It's an inflammatory reaction. They have to come to help clear the area and get it healed and ready to go. But when this happens, we get lysosomal enzymes. What do? Those lyse break down. So they start breaking down these cells, breaks down the glomerular wall. Remember, the wall is where, obviously, we're going to try and keep bigger particles out. Red blood cells should not be getting through. But we get a more permeable membrane, so now like red blood cells can get through those fenestrations and make their way in. Which is why, because the gates open up, you will get a little bit of protein as well, leaking in with some cases. Angiotensin and the leukotrienes contract our mesangial cells. Remember, the mesangial cells are in between the capillaries inside that Bowman's capsule. They can swell and get larger, and when they get very big, they compress those capillaries nearby and cause reduction in GFR when these mesangial cells swell. So they contract the mesangial cells, causing problems in the Bowman's capsule, reducing GFR. Bowman space may be damaged by fibrin deposition, and we get a crescent formation. So crescent formation, I have a slide, show you the histology. You'll see a renal slice of the renal tissue. You'll see these crescent formations in the cells. Because we have a reduction in GFR, distal tubule and water sodium reabsorption, leading to fluid retention. So they're going to fill up with a little bit of fluid. Water and sodium resorption increases their vascular and extracellular fluid volumes. Red blood cells can now pass into the glomerulus, go through all the tubes, the whole nephron, the loop of Henle, distal convoluted tubule, all that stuff, and will make its way through. Because of that, we get a red blood cell cast, and that's what this picture is showing you down there. This is a red blood, these are all red blood cells. This is all weird. Okay. They're in the shape of the tube. They kind of get stuck and they form the shape of the tube that it's going through before it passes out. These are found in the urine. So casts are found under microscopic examination of the urinalysis. So these are different types of glomerulonephritises and where they have their issues. The first one is anti-GBM. So anti-glomerular basement membrane. So we're going to attack the basement membrane, which is right here. That's the basement membrane, and we have our GBM antigen right there, and we have the anti-GBM antibody in the green Ys. So it's going to attack the basement membrane because it's an antibody against the basement membrane. So it's going to attack it. And you see here, it starts to attack and bind to the antigen on the GBM. But we have the anti-GBM antibody, so it's going to attack and turn it off and damage it. When that happens, you can see these fenestrations opening up in the area right here, so bigger cells can get through. So this is anti-GBM glomerulonephritis. You have anti-GBM antibodies floating around that attack the basement membrane of the glomerulus. That's one type of glomerulonephritis. The other one, immune complex glomerulonephritis. In this one, we have an antigen and an antibody that form a complex, and those get wedged in the basement membrane. So immune complex, we have to talk about antigens, antibodies combining. The last one is ANCA, A-N-C-A. It's one of these seropositive things for autoimmune disorders. So we have the ANCA antibody floating around. It's going to bind to the complement that's floating around, all these little red dots, bind to these white blood cells and cause issues. So this is another form of glomerulonephritis. So there's three of them. One is attacking the GBM directly. One is immune complex, which then invades the GBM, and the other one deals with the ANCA receptor. So those are described on the left. So signs and symptoms of acute glomerulonephritis. Gross hematuria is going to be the big one. Coffee colored or a smoky color to their urine because of the red blood cells that are there. What do red blood cells have inside them? The hemoglobin, when that gives you that dark amber color as they break up. So red blood cell casts are a classic indicator of glomerulonephritis because red blood cells are leaking in there now and they form to the shape of the tube. You may get some white blood cell cast. Proteinuria may be there as well, greater than 3 grams a day. Periorbital edema, they got puffy eyes. That's due to the protein being spilled into the urine. Lower extremity edema, ascites, pleural effusion, all from the same reasons. Problems with protein. The oncotic pressure reduces because you're losing the protein in the urine. So that goes down. You get some diastolic high blood pressure due to increased extracellular fluid volume. So that goes up, so the resting pressure in the system is higher because you have more volume in the system. Therefore, increased cardiac output and increased peripheral vascular resistance due to the acute glomerulonephritis. So one of them is called rapidly progressive glomerulonephritis. RPGN is the short for it, rapidly progressive glomerulonephritis. Kidney function is lost within weeks or months, so it's rapidly progressive. Usually kidney function takes a long time to get worse, but in this type of disease, it's rapid and it happens over weeks to months. Relatively uncommon, only about 10 to 15% of all the glomerulonephritis are due to this. 4 categories. One is a complication of an acute reaction. Here's your strep again, endocarditis, sepsis. Is it a complication of a multi-system disease? Remember, some of the other diseases will have their effect on the kidney, but it's not an actual kidney disease itself. Here's your lupus, rheumatoid arthritis is here as well. Drug exposure, penicillins, hydralazine, allopurinol is used for gout, and obviously idiopathic. So these are just 4 categories of rapidly progressing glomerulonephritis. So we talked about they get these glomerular crescent shapes, and let me do it in yellow. Okay. That is the crescent shape that changes on histology with rapidly progressive glomerulonephritis. So if you hear any questions about crescent-shaped cells, think RPGN is the answer. Again, common finding in elderly patients with acute nephritis. If untreated, goes to end-stage renal disease. Yes?
Is acute like a subcategory of this? Because I'm confused because it also has the crescent formation, doesn't it?
These are just in general, like glomerulonephritis is like the umbrella term, and these are all just different cases of them.
Okay.
So you have to do a biopsy to see this one. If you don't have the tissue, you can't see this crescent cells. Here's your chronic glomerulonephritis, continuing or persistent hematuria, and proteinuria. 10 to 20 years before you get to CKD. So the rapidly progressive one took some weeks to months. This one takes 10 to 20 years. End result, high blood pressure, contracted, scarred kidneys. They get smaller, and obviously renal failure is going to be there as well. Pathogenesis, again, what is the underlying cause for the glomerulonephritis? Is it antigen antibody complexes, or is it anti-GBM? What's the underlying cause for it? Again, structural hallmark, cellular proliferation, either in the mesangium, the space between, or the capillaries. So that's chronic glomerulonephritis. So here's like the summary again. Chronic, the most common form is crescenteric glomerulonephritis. They have the crescent shapes on there. Here's your post-streptococcal, and we haven't done any other ones yet. But you can see the most common one is the crescenteric one. Again, reviewing signs and symptoms, hematuria, proteinuria, reduced renal function, edema, fluid volume excess, and obviously hypertension. They're all related. Overloaded volume, having swelling. Those are the nephritic syndromes. They're all glomerulonephritis, but what is the category? Rapidly progressive, acute, chronic, or the other ones. Now we're going to focus on the nephrotic syndromes, dealing with protein issues. So a collection of symptoms, again, caused by glomerular disease. Key is greater than 3.5 grams of protein daily in the urine. So tons of protein. So how would you collect that? 24-hour urine collection. You tell them to go home, they get a jug, put it in the fridge, and every time they pee, they got to put it in there. 24 hours, bring it back. They measure it and see what's going on. So proteinuria is the underlying cause of all this, the nephrotic syndrome. The loss of the oncotic pressure, and they get swelling and puffy. So edema, again, there's no protein for that oncotic pressure. Hypoalbuminemia makes sense because all the albumin is leaving the blood, it's going into the urine. Hyperlipidemia, the liver is trying to make more proteins. The liver makes your cholesterol, which is a protein, so it's going to have to try building that back up. So you may get high cholesterol now because we're trying to replenish the albumin. Lipiduria, what's that? Lipid in the pee. Because we're making all these lipids, some of them will fall into go through the gate because now those podocytes are destroyed. They can get through, they'll wind up in the urine. What would the urine look like if it was a little oily, greasy looking from the fat that's in there? You may see some like frothy bubbles more often than others, but that's due to the lipid content. And that's a frothy or foamy appearance. Hypercoagulability. Why are they going to be hypercoagulable? What's the liver doing right now? Is it working harder or less? Harder, because it's making all these proteins. What also does the liver make? Your clotting proteins, right? So they're going to go up. So you're going to be in a hypercoagulable state because you have more of these clotting proteins floating around in your bloodstream as well. And altered immunity, they're going to have issues with common illnesses. Usually resolve spontaneously. It can progress to end stage, but for the most part, it just resolves on its own. There are 6 main disorders. Minimal change disease is the most common cause in pediatrics. It's called minimal change because there's minimal changes on the tissue, on histology. Nothing really changes, but they have all these proteins spilling out. There's a focal segmental, membranous, membranoproliferative, and here's your secondary causes, nephropathy and amyloidosis. So with these nephrotic syndromes, the permeability is increased. So these bigger proteins can get through now and get it into the urine. Basement membrane changes, foot processes change, those podocytes, to allow those bigger molecules to get through. Reduced oncotic pressure, therefore the hydrostatic pressure wins. And when the hydrostatic pressure wins, you get edema formation. So you get third spacing of fluid. That's the edema. It goes into the interstitial space. our RAS is activated, leading to further sodium and water retention, leading to further more protein loss and edema. So it's kind of like making things worse. Hyperlipidemia, inversely proportional to serum albumin concentration. So obviously albumin is dropping. The liver's like, we need to get these proteins up. They're going to start producing more cholesterol. Okay, cholesterol greater than over 200. Levels can commonly get to 600 to 700 for total cholesterol to try and get that protein content back up again. And you may see lipid casts from all the lipids going into the tubes. So we talked about that type of cast. That's one of them as well. Hypercoagulability, obviously altered levels of our clotting factors. Hepatic goes up because of loss of proteins in the urine. Hyperfibrinogenemia, impaired fibrinolysis. So are we going to be able to break up the clots afterwards? Nope, can't break them up either. Increased aggregation of platelets. So you can get a renal vein thrombosis. In rare cases, but it can happen. So here's just another, again, summary slide looking at an algorithm as you go through the process of how you go from glomerular damage, hyperlipidemia, and edema. How do they get to that point? And here's your summary slide between nephritic with the I, nephrotic with the O. Okay. Moving on to renal stones. You can read that. Gallbladder mixed stones, they come out. Kidneys, they don't. So presentation of renal stones. Flank pain that may radiate to the groin. You do CVA tenderness to see if it elicits any pain. Hematuria. What does macro mean? What? Large enough that you can see it with your own eye. So you can see the red in the blood in the urine. If it was microscopic, only on urinalysis would you see the red blood cells. But when it's macroscopic, you can see with your own eye that there's blood in the urine. Presentation may be complicated by the obstruction. They may have decreased or absent urine production, depending on where these stones got lodged. If it's just on like one ureter, the left one, if it's the right one got blocked, the left one's still draining, so you will produce some urine, not a whole lot, because you still got one working kidney, but the other one will get backed up. And these are the spots where it can occur. 75% will contain calcium, mostly due to idiopathic hypercalciuria, hyperuricemia, and hyperparathyroidism. You can have uric acid stones. What do we learn about uric acid? What does it cause? Gout. Okay, hyperuricemia, defective amino acid transport can result in cystinuria. And your struvite stones, they can be made with magnesium, ammonium, or phosphate. So the majority of them are going to be calcium, but they can be made up of other things as well. Dehydration favors stone formation. When you're really dehydrated, you're pulling out the solvent of the solution, so you can crystallize things out easier when you're dehydrated. That's why dehydration will cause kidney stones. Hypothesis, again, dilution of unknown substances predisposed to stone formation, and decreased transit time of calcium through the nephron. So the calcium is going slow through the nephron, it's building up in concentration, and if it builds up to a certain point, it will crystallize out a solution, and you get a stone that forms. High protein diet can also predispose people to stone formation if they're susceptible already. High sodium diet will predispose to calcium excretion. Therefore, you can get calcium oxalate stones forming. Other factors that are protective against stone formation, fluids. Citrate is a chelator. What do chelators do? They bind and pull things out. So it's going to bind to the calcium so that it won't precipitate out, causing a stone. Magnesium will do it, and dietary fiber will help prevent against kidney stones. Manifestations, the biggest one is going to be pain due to the distension of the ureter, renal pelvis, or the capsule. The severity of the pain is related to the degree of distension. So the more severe pain they're going to be in, the more severe the distension is or the obstruction is from the stone. If they have very low urine output, it could be bilateral obstruction. Or if they have a single working kidney, the other one doesn't work, and you block the working kidney, will cause drop in urine formation as well. What if the block was in the urethra? Will that block urine formation?
No.
It won't block the urine formation, it just blocks the urine voiding of the urine, but you're still making urine. The other ones will cause different problems. They are self-limiting, so once the stone kind of moves, the pain goes away right away. You can go on Thunder Mountain, that's used to break up kidney stones. I'm not kidding, it's a real thing, they do that. Because the vibration and the bouncing around is so bad, it's like it can dislodge kidney stones. The smaller stones, they usually pass on their own. If you want to find the stone, you have to make them pee in a container or a sieve that will collect the stones, and they can analyze those. So if you work in a hospital, they put the little hats in the urinal so that they can collect all the urine to see if they can catch the stone. Treatment, fluids, because we know fluids will help pass the stone, also prevent the dehydration. Bed rest, and just pain medicine will help take care of it. Major complications that can arise from kidney stones. One is this hydronephrosis, water on the kidney, where the obstruction is so bad, the urine that's being produced gets stuck at the obstruction and works its way back up, and starts all this water starts building up inside the kidney. Can cause renal damage when that happens. Infection or abscess formation can also occur. Renal damage due to repeated kidney stones. So when they start getting a lot of these, be very careful. Find out why they're getting kidney stones over and over again. Check their diet. Are they drinking enough water? What's another thing that can cause kidney stones to form that we kind of learned about with calcium? Well, hyperparathyroidism. What about medicines that we give? Thiazide diuretics alters your calcium, will cause kidney stones if calcium starts to build up in those cases. Opposite. Right, yes, but one of the other diuretics I think can cause it. But one of them will increase. The loop ones? Can't remember. One of them will cause them to happen. Hypertension due to renin production. Okay, we are done with renal